Thank you so much for that lovely introduction, and thank you all for inviting me to be here today. It's an honor. And I apologize for missing the talks over the last 2 days. I had an urgent surgery, so apologies for that. I heard the talks were phenomenal, and I hope that you enjoy today's lecture. Um, Please cut me off if I ramble or talk too much. I'm very passionate about this subject. And for the next hour or so, we'll be discussing phage therapy for the treatment of periprosthetic joint infection, a Canadian experience. These are my conflicts of interest. So for today's lecture, in terms of a roadmap or where we're going to be headed today, I wanted to start with discussing microbial ecology or the behavior of microorganisms in relation to implant-associated infections such as periprosthetic joint infections. And this is very important in the context of biofilm formation, orthopedic infections, and how these infections are so challenging from a clinical and surgical perspective. And then we'll dive into phage therapy as a potential solution to these challenging infections. And then lastly, we'll talk about what's next for Phage Canada. So whenever I approach implant-associated infections, I like to view bacteria and other microorganisms, including fungi and even viruses such as phage, as social entities. So just like human beings, microorganisms can be remarkably social on a microscopic scale. And there's this emerging field of microbial ecology, which can be very complex, looking at systems biology, looking at how pathogens can interact with the human host, with our immune system, in these microbial niches within the body. And they become very unique in terms of their behaviors, especially when there's underlying artificial materials, such as an artificial hip or a knee. And we're kind of moving away from looking at bacteria and pathogens as these single-celled organisms. And I like to approach it more as these multicellular organisms, especially in the context of biofilm formation. Very rarely are microorganisms, especially bacteria, existing as single-celled agents alone within an infected hip or a knee, or even in the environment. There is an intense competition for resources, carbon, nitrogen sources, etc. They're constantly trying to battle each other, but sometimes they're talking to each other on a molecular level to cooperate in order to exploit that microbial niche to survive and essentially make a home. And so we have these complex behavioral dynamics on a cellular level, kind of akin to these predator-prey dynamics that we see in animal ecology. And this is all happening in your hip when it becomes infected. So this group knows what biofilms are. I don't need to dive into this too much, but they're very interesting. And we've actually changed how we view biofilms in the last year or so. So we've moved away from that classic Pseudomonas cystic fibrosis model, that mushroom model, and we've gone into a far more complex dynamic model for biofilm formation. And there's a lot of these beautiful confocal microscopy images that our groups and other groups have been obtaining over the years. And you can apply all of this to what's happening in an infected hip or knee or an infected implant in the human body. We have these dense, complex, genetically diverse microbial communities with not only bacteria, we have fungi, viruses, and even phage, all living in harmony and sometimes not so much in harmony in order to exploit those resources within that microbial niche in the human body. We have continuous signaling, we have constant cell stress, we have physical stress. If we're looking at physical stresses within a hip, for example, cyclical loading, which can cause these unique genetic expression shifts in biofilms on implants in the hip, for example, changes in colony density, resources, and we have this beautiful coordination of genetic expression, movement, and behavior all happening in that hip. We have a reduction and diffusion of potential antibiotics, as we know. The further you go down that gradient within the biofilm itself in that three-dimensional space, and phage can help combat that, and we'll talk about that later. But then we have this idea of the dormancy spectrum, which is kind of a newer thought about biofilms, where the further you go down, we actually have bacteria essentially going to sleep. And, a lot of antibiotics, they need actively dividing cells in order to be killed. So this is yet another tool in the microbial toolkit that bacteria have in order to combat antibiotic activity for these infections. And there's, on top of that, this whole other layer of complex interactions between the bacteria, not only themselves, viruses, fungi, but immune cells, and even the implant itself, and host cells. So it becomes this complex rat's nest of information that we're only just beginning to tease apart for orthopedic infections. And this is kind of an aside, but the study here shown on the bottom, it's very difficult to sterilize anything really in the environment. It's almost impossible, some people argue. And this is one of those studies that looked into that, where they found bacteria using fluoroscopy on intensely sterilized titanium implants. And as a further aside, one of my colleagues works at NASA, and her job is to sterilize spaceship hulls. And she said she cannot do it. She said she was able to isolate bacteria that use the disinfectant on spaceship hulls as a carbon source. So if we can't disinfect a NASA spaceship, how can we combat these artificial implant infections in the human body? And we'll get into that over the next few slides. So just to kind of delve into this world a bit more, I find it fascinating. This is one of my favorite studies here on the left. We have a colony of Bacillus subtilis, the large white colony. And then we can see Staph epi next to it, a neighboring colony that's more yellow. And you can see that Bacillus subtilis is producing something, a molecule that is lysing that Staph epi colony. And this is a very elegant study, and it really paved the way for other studies where we're trying to find novel diagnostics and therapeutics in the setting of these complex microbial dynamics in human infections. And the Bacillus subtilis only produces this antimicrobial molecule only when Staph epi is present in three-dimensional space. So it has to be close to it. But alone, it does not produce this molecule. And my colleagues and I in the States, and right now we're expanding on this type of research. The study on the right is kind of taking this work a step further and looking at how genetic expression and proteomics change on these artificial implants between bacteria and our immune cells. So at that surface implant level, how can we exploit the shift in proteomics and try to find new molecules, new antimicrobial molecules, and new biomarkers that we can use to predict these types of infections and prevent them? So very interesting research going on right now. So overall, we have this complex interaction of microorganisms happening right here in our bodies with these artificial joints. What's the net outcome? Is it primarily cooperative? Is it competitive? Well, every couple of years I see papers arguing for or against. I think it just depends. It depends on so many different factors. And there's really a balance. It depends on the organism. There are really hundreds of factors that can affect this. But there's this unique spatial distribution and composition within a microbial niche. And one of my other favorite papers was published in Science a few years ago, here shown on the bottom, where they are kind of exploiting this a step further, where they sprayed implants with lactobacillus, which is essentially yogurt, a yogurt organism. And they found that when they sprayed this titanium hip implant with lactobacillus, it actually promoted osseointegration of the implant, and it prevented MRSA from binding to the implant, and it had anti-biofilm activity, which is very, very interesting. So I'm going to kind of step back and go towards more of a clinical approach. So when I see patients with these infections, so implant-associated infections can range from anything from neurosurgical implants to tracheal stents to aortic graft infections, biliary mesh, catheter-associated infections, line-associated infections. Anytime there's artificial material, bacteria will behave very differently. They will have a huge shift in their expression, and their entire job is to try and exploit that microbial niche and make a home. So I have to think about that in the back of my mind when I'm approaching these infections, in particular orthopedic implant-associated infections. But then you also have to look at the surface chemistry of the implant itself. So is this titanium? Is it more cobalt-based? Is it more of a rough surface? Do we have nanospikes? Is it plastic? What type of plastic? All of these on a cellular level can affect how these infections will progress and how difficult they will be to treat clinically. And then you have to think about the biophysical properties. So is this a cardiac valve infection, for example? So, the heart is beating so quickly, and bacteria will take advantage of that. So, for example, Pseudomonas in such a turbulent biophysical space, you'll get something called streamers, where the Pseudomonas will kind of grow end to end and form these little fibrils to try and exploit those high pressure changes in the heart. So it's just very interesting how these bacteria will change their behavior versus in a hip, Pseudomonas won't do that. And then you have to take a step further and look at the host itself. So is this an immunocompromised host? When I see patients who are bone transplant patients, for example, they're very immunocompromised, they're very sick. And we tend to get a shift in microbiology towards more molds. I've seen devastating mold infections, more yeast or fungal infections, and then we get more enterobacterales. So you have to think about that, what type of biologic or steroid are they on, etc. And then the mechanism of infection. So how did this organism get into that so-called sterile space that infected hip or knee? That can also affect how serious the infection is and how I'm going to treat it. So if we zoom in a bit onto orthopedic infections themselves, so many of us have loved ones who've undergone, shoulder replacement, knee replacement, hip replacement. It's one of the most common surgeries that we have in Canada, especially with our aging population. Joint replacements are becoming very common. But unfortunately, approximately 1 to 2% of these patients, and that number can change a bit depending on the host and where you're located, what center, and what type of procedure you're having. But approximately 1 to 2% of patients who undergo these primary joint replacements are going to develop this devastating infection called periprosthetic joint infection, or PJI. And where I come in is that it's really once you have that primary infection, your risk of repeat infection skyrockets for your revision. So it can be as high as 15%. And if you have underlying hematologic malignancies or cancer, it can be even higher. And once you have that established infection, it's incredibly difficult to eradicate it. And that's why they pay me the not so big bucks. And there is a significant burden on our healthcare system with these infections in the order of tens of millions of dollars, billions of dollars if you're looking at the States where you have larger healthcare systems and a slightly different healthcare model. They're devastating outcomes for our patients. I have patients who are unfortunately suicidal. They have horrible depression. They get chronic pain. And I have patients on operation 10, 11, 12, 20, 21, 22, to the point where they have to get a high limb amputation to try and fix this devastating infection. So really difficult disease to manage and to diagnose and to treat. And we're going to talk about that next. So when I'm approaching these infections, PJI, there are a variety of diagnostic criteria. I like to use the MSIS criteria, but the simplest one would be IDSA, for example. But there's a whole bunch of these, and you actually need quite a few different diagnostic modalities in order to diagnose these infections. So unless you have an exposure of the underlying implant or a draining sinus tract straight to the implant, which is where the bacteria literally eat away through the tissue planes to the implant itself, that's a slam dunk diagnosis. But unless you have that, which is more so in chronic severe cases or recalcitrant cases, you need all of these different pieces of information to diagnose these infections, and it can be quite challenging. So we have our standard microbiology. Okay, that's great, but unfortunately, up to 40% of PGI are culture negative, which makes my job very difficult because at the end of the day, I want a microbiologic diagnosis. And unfortunately, so many patients are getting pre-sampling antibiotics in the community from their family physician, where they find some, doxycycline in their cupboard and they take it once their hip's a bit sore or red, and that can cause false sterilization or false negatives. So standard culture is not that great. And then we have to look at history and physical exam. We have patients, oh, my knee is hot, it's angry, it's sore. Or we have patients who say, you know what, I just don't feel great. and they present very non-specifically. Their knee's not that swollen. There's no overlying erythema or cellulitis. And they just go, yeah, I just don't feel great. And you go in and they have rip-roaring pus and a rip-roaring infection within the knee. So you have to look at the tempo of the symptoms, when their last surgery was, their type of surgery, their history of microbiology, if it exists. And then we have biomarkers. This is a whole other area of study I'll talk about soon. We have our CRP, our ESR, our interleukin 6, but these tests are not good. Our alpha defense, and I'm not a huge fan of it, but in the States they use it a lot, this point of care assay. What we really need, in my opinion, my humble opinion, is we need to create these multiplex assays where we have multiple biomarkers all at once in a point of care assay that we can bring into the OR, dip it into the synovial fluid, and we'll have a highly specific, highly sensitive assay right then and there. Instead of CRP, ESR, I have a lot of patients with lupus, rheumatoid arthritis, their biomarkers are already out of whack, and it's not really helping me as a clinician find out if we're winning the battle against their PGI. And then there's histopathology. So how many PMNs or neutrophils are we going to see under the microscope? When we go in and we take a bit of tissue, is it safe to reimplant? Have we gotten rid of the infection? Histopathology is not great either. And I think that we need to be collecting far more than just one histopathology piece. We're missing things like foreign body reaction and, things that can mimic infection on a cellular level, but it's not actually an infection. And then we have imaging. We have things like micro CT, MRI with metal suppression. And then, of course, something, simple as a plain film. Do we see that the implant itself has loosened? Is that due to infection, kind of a slow growing infection or non-virulent infection like Cutibacterium acnes? Or is there something more sinister going on here? And then lastly, we have some really interesting molecular and rapid diagnostics that are emerging, like targeted metagenomics, multiplex PCR-based assays, even phage sensors, really cool stuff emerging. I saw a paper looking at using isothermal titration calorimetry to detect heat signatures given off by single bacteria within hips. This is a really interesting emerging area. So, chronic orthopedic infections are devastating. So I see patients like this all the time in my PGI clinic. Very challenging disease to manage. These are two patients. One has a chronic shoulder PGI, one has a chronic hip PGI. And you'll notice that there's no metal, there's no artificial joint, there's no joint at all in these two poor patients. The shoulder's completely been resected multiple times, and the hip's been resected multiple times. So even despite removing the infected implant, removing all of the biofilm that the surgeons can see grossly, they don't have microscopic vision, but as much as they can remove, these patients still relapsed tens and tens of times with these infections. And the patient on the left there, he has a chronic MSSA or Staph aureus shoulder infection. So now he has a flail arm, and I still have him on chronic suppression because even without the metal and these repeat resections, he's still relapsing. And the same thing with this poor patient with the girdle stone. She had multiple girdle stone procedures and supprastrectomies where they try to cut out any grossly infected bone. And she, after being on vancomycin and Scepter for years and years, still relapsed with MRSA. She had MRSA bacteremia. So why is that? And it all comes down to this, the biofilm. So this is a really nice in vitro electron microscopy image our lab took of MRSA on a titanium screw. And you can see it's just this beautiful, complex, grape-like structure. And this is very simple. This is an in vitro electron microscopy image we took. So these are some of the infections that I see every day. And I hope no one here has a queasy stomach. These are actually some of the lighter infections that I could find for pictures. Thankfully, all of these patients, I've gotten control of their infections, but you have to be patient. And I tell my patients, it's not you. We just need to kick the bugs out. We have to be slow, we have to be cautious, and we have to really be careful about this. So, the one on the left there, that was Sarisha. I remember that like yesterday. She almost died. She was septic when she presented. They just kept throwing antibiotics at her and nothing was really working. Thankfully, the surgeon I was working with, we were able to get a hold of it. And she is doing fantastic right now and actually wants a joint replacement on the contralateral or other leg. This poor lady here with a spinal infection, she had spinal hardware everywhere. We finally were able to remove all the spinal hardware. That's not an easy surgery because it's your spine. Very high mortality and morbidity associated with spinal surgeries. She had a streptococcal infection, and you can see there's a bit of overlying fungal infection as well. We see some nice satellite colonies. But thankfully, a year later, she is cured. And these are just some other examples of infections I see all the times of the knees, hips, and interestingly, the photo I have on the right there, I think that's more of a foreign body reaction. I mean, yes, there is an infection, but there's so much caseous proteinaceous fluid there, and this is just to show that these infections are complex, and you have to kind of broaden your mind about what else can be going on. If you're using the correct antibiotic, we've done everything surgically, and they're still failing therapy. So he has two things going on there, unfortunately. So, but at the same time, we have infections that can present, as I said before, very indolently. So that knee on the right there, this patient had a rip-roaring staph epidermidis infection, one of the worst I've seen. And his knee looks pretty normal clinically. It's not really swollen. He said he's had kind of grumbling pain for years. He came in for a routine checkup, and I saw that his CRP took a bump. And he said, I had a fever the other day, but I feel great. And he was actually he said, I don't want to be admitted. I want to go home. I don't want to get a tap on my knee. I eventually convinced him, and he had a horrible knee infection. So you have to look at host factors, the organism, inoculum size, virulence, antimicrobial resistance or tolerance, the surgical factors, the tempo of infection. Is this more of an early acute infection versus late chronic? That can change our microbial, or we get a shift in our microorganisms. You have to look at the implant type and location, the surgical approach that we use. Did they use more of a lateral approach or a posterior approach? Were they on suppressive therapy? The duration of therapy, how does this antibiotic work? Are we using an anti-biofilm antibiotic such as rifampin? Any other adjunctive therapy? The mechanism of infection, was this introduced at the time of surgery, which unfortunately happens fairly often, or did we have hematogenic seeding? So for example, I often ask my patients, did you nick yourself shaving? Did you floss a bit too hard? Did you stub your toe? Did you work out a bit too much? I mean, all these things can affect the mechanism of entry of that bacteria, that organism. I had one patient who had a little scab on her knee and she didn't even think about it. And she ended up getting horrible Staph aureus bacteremia and it seeded her hip implant and she became quite sick, multistatic infection. So, and then of course the host itself. So are they on any immunomodulatory therapy and do we have a sinus tract formation? So as I said, when you have these chronic infections, the bacteria kind of crawl away and chew away through the tissue planes, and they tend to be more polymicrobial in nature. So it's important to take that into account as well. So this is kind of everything that I've talked about so far. So I like to break it into our biofilm formation, the implant type, and then the host innate and adaptive immune responses. And we're looking at chronic PJI. And then there's a whole bunch of interesting factors that I touched on. So with the implant itself, you have to, when you're designing these implants, which is what I'm doing with some of our bioengineering colleagues right now, you have to look at biocompatibility of the device. So you want to create an implant that is going to be biocompatible with human tissues. You want it to integrate into the bone and tissue, but not too much. You don't want it to lock in so that you're more likely to get fractures, which can predispose to infections, but you don't want it flopping around, which can also predispose to chronic inflammation, foreign body reaction, which can cause recruit actually for biofilm formation as well. So it's a nice balance. And then you have to look at hydrodynamic flow variations, cyclical loading, for example, when you're looking at joints. There's a lot of physics involved and biophysics for this. There's a very cool paper I read where they looked at nanospikes on implants, which mimicked cicada wings, for example. So cicadas have antibacterial wings because they have these little nano pillars, and bacteria literally impale themselves. So, but when you apply that to the human body, it can cause local inflammation because you're impaling human cells as well. So there's a lot to take into account. And then for host, innate, and adaptive immune responses, if we get into that a bit more in terms of the molecular details, one of the reasons why these infections are so brutal to manage is because of this. So we have bacteria such as Staph aureus, Salmonella. It's a variety of pathogens that can actually be taken up by our macrophages and various immune cells. And they can actually invade bone cells as well, osteoblasts. And they remember that metabolic dormancy spectrum, they can actually turn down their metabolism and kind of hide inside our host cells, our bone cells, inside our various immune cells. There's even mechanisms for metastatic bone and joint infection through this process, where bacteria will be taken up by macrophages and they'll circulate in the blood and then deposit into other sites, other bones. So inadvertently, our immune system can be causing harm. And then if we kind of zoom in a bit more on the oil-seam network or the lacunar network within bones, we know through various microscopy studies that bacteria can form these microcolonies that we can't see. We don't have microscopic vision. And they can kind of form these microcolonies into the bone network, and we can't cut them out because we can't see them. And we have, sequestri of infection. We have a variety of adhesins, PPPs, M-scrams that are involved in that process itself. And then we have biofilm formation on the implant itself and surrounding tissues. Very dynamic model. We have, again, M-scrams involved, various coagulases, EPS productions involved, and dispersal mechanisms as well. And then if you have abscess formation, we all know how abscesses form, but when these are actually punctured or you undergo an irrigation and debridement in the OR, you can inadvertently release bacteria into the bloodstream and cause bacteremias, and cause metastatic infection as well. So these bacteria, they're really clever and they are primed in order to exploit this microbial niche of bone and joint infections. And this is why even when you cut out everything, you still get persistent infection. So that sounded pretty grim. So what can we do to treat these devastating infections? Well, our lab is focusing on three major areas. So the first one is we want to prevent that biofilm from forming in the first place. So in order to do that, we want to be able to be sure that we have an accurate and rapid diagnosis of PJI to prevent that mature biofilm from forming in the first place. And that kind of dives into point two. So we want to prevent biofilm formation through either small molecule inhibitors or various other mechanical disruptors that we can use. And then lastly, what about phage therapy? What role does phage therapy have in preventing orthopedic infections? So very briefly, this is my postdoc, Dr. Tanver. He is fantastic. This is a clinical trial that we're running right now. It's a multi-center trial. And we're using a multiplex PCR-based device that you can use directly on synovial fluids. And this is some of our preliminary work and published work. And we're combining this technology with metagenomic sequencing to diagnose orthopedic infections as rapidly and accurately as possible. But what's interesting is that with this study, it's very difficult to detect kind of commensal organisms like Staph epi and Cutibacterium, for example, depending on whether you have a shoulder or hip infection, for example. These are not on panel for many of these rapid diagnostic assays. And that's a whole other discussion in and of itself. I think that they should be on panel, but what we did is we developed a diagnostic algorithm that kind of circumvents that problem because Staph epi causes up to 40% of PJI. So if that's not on our rapid diagnostic device, we're missing 40% of these infections. So we've combined it with the metagenomic sequencing step to kind of miss that 40% gap in order to more rapidly diagnose these infections. And our team has taken it a step further in that we are applying this to pediatric cases. So Kingella kingae, which is shown here on this blood agar plate, it can be a common pathogen for pediatric non-implant associated infections. And diagnosing these infections in kids is a whole other challenge because, they're not really verbal depending on the age, and, they just have a limp. And I mean, kids are always bumping around and running into things, and it's difficult to know whether they have a life-threatening infection right away or not. So this panel has Kingella kingae on it. So we're applying this to pediatric as well as adult cases as well. And we're getting some interesting results. So we're looking at things like whether we have improved patient outcomes with this diagnostic pathway versus standard microbiology. And then the next step would be to combine this with phage biosensors and ELISA modifications. So another kind of area that our lab is working on, this is another study we're doing right now with our rheumatology colleagues. So I'm very interested in, someone presents with a hot knee or an angry joint. Is it infected or is it not? And we're using proteomic-based assays to find new biomarkers to more rapidly and accurately diagnose orthopedic infections and to be able to differentiate these infections from things like lupus or ankylosing spondylitis or other autoimmune phenomena where you have an angry swollen joint that may mimic infection, or like gout, for example. And often in my clinical practice, I'll have patients with both. Because these autoimmune diseases can actually promote infection because you have immune dysfunction locally within that joint. And so our preliminary data shows that, yes, we know IL-6 is important, but interleukin-8, interleukin-1 are VEGF factors. TNF-alpha, CCL11 may be more so upregulated in PGI versus rheumatoid arthritis, where we have more of a peak within RAGE, interferon gamma. And then aseptic loosening, we have more of a peak with RANK-Ls, OPGs, MMP1, and MMP10. So that's just, a brief little overview of some interesting work there. So if we kind of go focusing more into that third point, phage therapy, I kind of like to look at things in terms of their function. And I know Darwinian evolution, nothing has a function, blah, blah, blah. But humans are kind of dumb and we like to think about things in terms of their purpose and their function. So phage in the environment, and as well as in the human body, and in the context of these infections, they are responsible for a massive amount of horizontal gene transfer. So transduction, transformation. We have metagenomics, where our environmental viromes harbor a massive reservoir of antibiotic resistance genes, which confer multi-drug resistance. We all know this. But they're critical mediators of genetic exchange between pathogenic and non-pathogenic bacteria. And this is happening inside humans. And then there's the idea of temperate phages and microbial fitness. When we're designing phage, phage are very safe if you know what you're doing. We've all heard that, they're safer than antibiotics. Yes, but you have to know what you're doing. These have to be pure preparations. And it's important to know that phage can confer resistance. They can actually cause massive immune responses. They can stimulate bacterial phagocytosis, opsonization. We can have fine tuning of cytokine responses. There's even some data emerging that phage influence adaptive immunity and modulate antibody production, for better or for worse. So there's a lot of things that we don't know, and we have to be careful with when we're designing these things and giving them to human beings. And then there's this idea of, the phageome. There's all these omics, who knows? But there's the idea that there's healthy gut phageome, HGP versus diseased gut phageome. And there's some data emerging showing that some cancers, some hematologic malignancies, and some diseases such as Crohn's disease and ankylosing spondylitis have a shift in the type of phage that are present in our guts. And then, to get back to the population dynamics, phage play a huge role in predator-prey dynamics with bacteria in the human body as well. So they're regulators of various bacterial populations, which is interesting. So very briefly, I'll get into our single patient trial. This is kind of what started my fascination with phage. And we recently published on this case. A picture is worth 1,000 words. This is a plain film X-ray of our poor patient. Her name's Thea. She's showing here. She's happy and doing great now, thankfully. But you can see that this is a horrible X-ray. This poor woman slipped on ice, roughly a decade ago and kept dislocating her hips over and over and over and over again. She had a chronic infection that kind of got missed here and there. And by the time we had seen her in her PGI clinic, she had a severe life-threatening staph epi periprosthetic infection of the pelvis and hip. And you can see with this patient, I didn't really talk about, surgical treatment of PGI, but we think that the best way to treat these infections is to remove all the infected hardware, clean out all the peri-implant infection, and then give antibiotics. But as you can see, based on this X-ray, you can't cut this poor woman in half. I have seen hemipelvectomies done in severe cases, and they are devastating. And this woman would not survive a procedure like that, and that just would not be fair to her. So when I had seen this patient in my clinic, she had 10 operations of the right hip and pelvis. She had a severe drug allergy called DRESS, which prevented me from being able to give her two major antibiotic classes. Couldn't give her glycopeptides or beta-lactam antibiotics, so very tied in terms of antibiotic therapy. She had a severely multi-drug resistant staph epi strain, highly virulent, kept getting infected with this organism over and over and over again. And on top of that, the only therapy that I had to give her, which was daptomycin, she was having severe toxicities associated with that antibiotic. So she had neuropathies, tingling pain, and myopathies in her legs and hips. And after being on another prolonged course of these antibiotics, when at time I had seen her, she already had a draining sinus. She had pus pouring out of her hip, which is shown here, and she was septic. She had fevers and chills, and she was confused. So this was a life-threatening infection. The surgical team had written, we're going to palliate this patient. There's nothing we can do. It's just devastating. And when I saw her in clinic, I thought, we need to think outside the box here. There has to be something we can do to outwit this bacteria. And you can see here, these are the MICs of the staph epi. I asked for things like ceftobiprole, ceftaroline, but there's no CLSI breakpoints for these. And remember, she had DRESS, so I couldn't give her a beta-lactam because she had that severe allergic reaction. And the dermatologist said, nope, you're going to kill her if you give her that therapy. So we were really, really stuck. So that's where we turned to phage therapy. And when we were designing this study, there's not a lot in the literature. There's case reports here and there, but there's so many considerations we had to take into account when we were designing the study. So monophage versus a phage cocktail, there's evidence for and against. Phage cocktails, as we all know, it prevents resistance. But at the same time, which is what we found, you can actually get antagonism of phages. We had one phage that was doing all the heavy lifting on our kill curves, so we decided to go with the monophage preparation. What dose? If you go too high, you can get fibril formation, precipitation. If you go too low, you're not going to get our nice burst killing waves. So the pharmacokinetics need to be taken into account. And what about frequencing? Should we do what our colleagues in the States do at Stanford? Should we do sequential dosing? Or should we just give, one dose a day, twice a day? We decided to do BID dosing with our monophage preparation. And then, of course, it's important to do standard of care treatment. You can't just give phage therapy on your own and just hope for the best without giving an antibiotic that's a good anchor antibiotic to work in synergy with that phage. And then, do we give this therapy topically during the OR? How much? You just dump it in. There's so much to do here. Is there hydrogel release? Do we give it orally, intravenously, intra-articularly? Duration of therapy. Should we space it out with rifampin? There's some evidence that rifampin can actually inhibit or block phage formation. And then, of course, there's the regulatory hurdles. So very briefly, this is in our paper, but it's important to ensure that the phage preparation is safe. And that's exactly what we did in conjunction with our colleagues at Cytophage Technologies. You need your sterility certification, endotoxin levels, physical chemistry parameters, final product identity measures, electron microscopy, genetic sequencing, things like that. Has to be a lytic phage. We don't want to give a tempered phage, but that's a whole other discussion in and of itself. And you just want to, verify product fidelity, which is what we did. So very briefly, regulatory hurdles. My goodness, I feel like I aged 20 years with the with the regulatory hurdles for this study. Our studies that we have ongoing now are going smoother in some respects. There is a lot of misinformation out there. In my clinical practice, I have patients coming from Eastern Europe, the States, even in Canada, with kind of homeopathic tinctures that they got from some company that they found online. And there's just a lot of misinformation surrounding what phage are, how they work, and it's important that we found that Health Canada as a regulator is very knowledgeable for the most part about phage therapy, but really it's local hospital boards and ethics boards that really need to be educated on this therapy, and how safe it is if you know what you're doing and you're working with a reputable lab. So there's a lot of red tape surrounding this, and it's one of the biggest reasons why we can't give phage therapy overnight for a critical infection, because that's honestly where we need to be. We can't, we got this kind of down to an art in terms of timing, our research group from the regulatory perspective, but it needs to be streamlined so much more. And this is a lovely slide Dr. Tanver made that kind of summarizes phage therapy developments, gaps and challenges, solutions, and future outlooks. But really, I won't talk about all this, but what we really need is, in conjunction to clinical trials that are more higher quality. With PGI, we're not there for an RCT yet. We're really not. PGI is a remarkably heterogeneous disease, and phage therapy is not something we're going to get overnight. Unfortunately, not yet, but we're pushing for it, and we get to lobby the government for that in order to design high quality clinical trials. But in conjunction to that, we need good basic science models. We don't even understand the pharmacokinetics of phage. We don't even really understand how they work in biofilms yet for certain organisms, especially in vivo systems. Like, we need both of those research arms to come together, and we need to have these centralized data sets that have good phage bacterial matches. And our team's working on that, and I know there are some other groups working on that as well. We really need to kind of combine our resources instead of existing as scientific silos. And then on top of that, we need to really fast track the regulatory pathways. So Health Canada, as I said, they're great. They can give us approval in a couple of weeks. They've been fantastic, but it's the local hospital ethics boards that, I mean, for many clinical trials, they can take years to go through. I mean, when I was at Mayo, they would approve studies in a week. It's just it's a very different system, where in the States, they focus more on the patient, so the patient aspect. Whereas in Canada, there's more of a focus on how can we protect the hospital legally. So it's a very defensive process, very different mindset versus our colleagues in the States and in Europe, where it's more scientific and discovery based approaches and focusing on patients versus more that kind of defensive, bureaucratic pathways. So I kind of talked about a lot of this, but with personalized medicine like phage therapy, this is an emerging area, and the biggest thing is we need standardization of our protocols, which is what our team has. But on top of that, we need to kind of meet with those regulators and say, look, we have a patient who's dying. We need to get this therapy in a week. We have a phage, we have our match, we have our all of our testing done, all of our laboratory ducks in a row. We want to give this therapy in a week. Let's do this. And we are working on that, and we are getting there. But really, without that, we're not going to get high quality trials being done anytime soon. And then, I won't talk too much about GMP, but there is some data to show it shows a higher barrier to entry. We have hindrance of rapid access. It isn't flexible and kind of is at an odds with personalized medicine and creates more bureaucratic slowdown. It also limits the diversity of our phages. Um, and then, I think another strategy we need to implement here in Canada to make more phage readily available is to integrate phage therapy into our national AMR strategies. I think that's kind of a nice segue into making this more readily available. And I don't need to talk to this group about, the doom and gloom of antibiotic resistance. I mean, we are in deep trouble. We really, really are. But phage is a tool in our toolkit that can help with combat AMR, and Canada needs to get on board with that. So my colleagues in Europe and the States, I mean, they don't need to convince the government about that. This is a priority for them, and they're working for it. So phage can disrupt implant-associated biofilms, as we all know. We have more targeted approaches, which can, uh, protect our microbiomes. We have fewer side effects than many of the antibiotics that I give our patients all the time. They can be effective against many MDR pathogens in PGI, especially Pseudomonas. And, Staph epi, I've seen some of the worst PGI with Staph epi. I don't want to hear anymore that Staph epi is a non-virulent organism. It behaves so aggressively as soon as there is a titanium implant. It's fascinating. And then there's the idea of potential synergy with antibiotics to restore antibiotic sensitivity. And that's where we're working on another study right now with Dr. Houghton and Hanelli and Dr. Tanver, where we've designed small molecule inhibitors such as these antimicrobial peptides. And we're playing around with these tryptophan placements and hydrophobicity for these peptides. And what we're seeing is that they're very active against a variety of our gram-positives in PGI, our gram-positive PGI isolates, so especially Staph epi, as well as MSSA, Streptococcus species, and Corynebacterium, which is interesting. So right now we're working on biofilm assays with these clinical isolates, and the next step is to combine them with phage in order to see if we can get any positive synergy for antibiofilm formation. So I think I have 5 minutes left, so I'll just jump back to our single patient phage trial. So our patient, we decided to design the study such that the patient received 7 times 10 to the 9 PFU per dose, which is kind of in that sweet spot, we think. But again, who knows? We need far more data to know what that optimal dosing is for each infection and each patient, and different organisms and colony loads and things like that. So we gave the therapy intra-articularly right into that infected hip with a catheter, thanks to our radiology colleagues. And we also gave it systemically, intravenously. Twice a day, it was a monophage preparation over a planned 2-week course. And of course, we gave concomitant standard of care therapy. You shouldn't give phage therapy alone. We gave her adjunctive daptomycin at low doses to try and minimize that toxicity, as well as adjunctive rifampin. And what's really interesting, and this hasn't been reported in the literature before, the whole immune response and immune tolerance with phage really needs to be studied more. We found that there was an immediate anaphylactoid-like response, which is not uncommon. That's well reported. But what was interesting is that she had mild hypertension with rebound hypertension. That hypertension was very interesting. Low-grade fever, some rigors, chills, and wheezing that lasted about 30 minutes, primarily after the intra-articular dose. And she reported that, the patient said, I feel way worse with the intra-articular phage versus the intravenous phage. And I didn't expect that. But when I thought about it, her infection, the burden of infections in the hip, and perhaps, with all the lysis and, phage activity happening in that microbial niche, perhaps that's why she had such a marked immune response. I mean, that in and of itself could be a whole separate study, which is really cool. So we're looking at that right now as well. And these anaphylactic responses became less and less. Perhaps there's immune tolerance, but what does that mean? on a cellular level, we don't really know. There's a lot of hand waving about interleukins and cytokines. And then the completely resolved at around day 5 of treatment. And you can see that her inflammatory markers beautifully trended down to normal at 12 months follow-up. And this is the first time her biomarkers, her inflammatory markers in the serum have actually normalized. And within about 2 weeks, she had improved mobility. There was no more drainage of pus from the hip. She had a bit of a hepatitis, which again is described in the literature. It was mild and self-resolving, which also kind of trended along with the biomarkers. So we're pleased to report that there was positive outcome with this patient. She survived. This poor woman was going to die in probably 1 to 2 months had we not intervened. She had complete wound healing at about 1 month post-phage treatment. Functionality improved within the right hip, and her pain improved within 3 months post-treatment. And at 10 months, there was no recurrent surgery, complete normalization of her inflammatory markers. And currently she is living at home and throwing tea parties. So uh, she is living her best life. So, and then very briefly, for the last 1 minute, next steps. So our clinical course, an outcome aligned well with the limited available literature in this budding area. We need further data. So we need higher quality data. We need standardization of protocols. And then we really need that regulatory and logistical aspect to come together. So as I said before, our team has all the pieces. We have everything ready to go. It's just that regulatory aspect. You know, right now, we could give phage therapy to 50 patients, 100 patients. We're ready to go. But it's the mountains of paperwork and bureaucratic hurdles that we have to go through in order to provide a therapy that is widely used in Eastern Europe for years and years and years. And the only reason it's not widely used here is because of geopolitical history. I won't get into, Russia versus America and, penicillin, but that also is very fascinating, right? So anyway, future work and current work, we currently are working on larger trials, both in Canada and the US. And we're expanding to other IAIs and chronic infections. We really need to work on PK data, pharmacokinetics. We're working with our bioengineering colleagues. This is Dr. Scaiano. He's lovely. He's working with our lab in nanotechnology and nanoparticles. So we're hoping to create these silver conjugate molecules to rescue old antibiotics in PGI and to actually conjugate them to our effective antimicrobial peptides, as well as phage. Yeah, so thank you so much. Well, I talked for an hour. Thank you so much to my team. We have a lot of great collaborators around the world, and I'm very excited to keep working in this area. Thank you so much.